before we start, we have an eminent panel here in front of us. I have Dr. Sushil from AIIMS, Mr. Dwivedi from Rajiv Gandhi Cancer Institute, and then Mr. Surjeet from Rajagiri Hospitals, and also Dr. Rishabh Bandari from Medisha Technologies. Our panel is the topic that we have for a panel is very interesting, and also a lot of controversies that may come up about how AI would help in building the health ecosystem. And as we were discussing before we came up on stage, one of the views was, do we call AI as artificial intelligence, or in the healthcare ecosystem it should be called as augmented intelligence or assistive intelligence? And this is going to be a big game changer for most of us. But at the same time, when we talk about AI, we need to keep in perspective three important things. How is it improving the population health? Because we as a country, one of the largest populations in the world, and helping in accessibility. How is it enhancing the quality of care? And finally, does it make healthcare more affordable? These are the primary three themes that we'll always be touching upon when we talk about AI, because if it's not achieving any of these, then that's something which we need to relook at. And more importantly, because of AI, the patient of the future is also looking at it differently, right? The new gen, the Gen Z or the Gen Y, they are more exposed to these technologies, and they are going to exert pressure on the system, because even before they visit a physician, they look at ChatGPT and try to find out what is it, and they try to do a self-diagnosis. And then how is the ecosystem equipped to handle that particular set of population as well? So the consumer of the future is going to exert pressure on the system, and therefore as a ecosystem, how are we going to address those? So in today's panel, in the next 30-40 minutes, we will talk about some of the use cases in the industry, some of the pitfalls, how do we build a connected ecosystem, and what needs to be the effort coming in from various players, whether it's private hospitals, governments, educational institutions. So how this entire ecosystem should work together. So with that quick context, maybe I will want to open up a question to you, Dr. Sushil, is, with your experience and the decades that you have in this industry, and especially from a technology perspective, where do you think these technologies can shape patient care? And what do you think has happened in the last 3-4 years, big disruptions that have happened in this industry using AI?
Thank you, Elite organizing team, to invite me in such a wonderful topic in the panel. I am Dr. Sushil Meher. Last 32 years, I am working in IT in healthcare in AIIMS, New Delhi. When we are talking about AI, I was teaching AI to the bioinformatics students last 20 years. So I understand the depth of the AI, how it will be used. But I'm taking to a little bit further. What is the development of AI in the generally we are speaking? When you are a BTech or MTech students, you have learned only data and informations. But AI at that time was also there, but nobody was talking about that. When data has been generated in different sources, it has started, we are talking another layer after data and information, it is called knowledge. That is called data analytics, what we are talking. After that, when it has worked perfectly, then people started using another layer. It is called intelligence, that is AI. And we are era of AI. But the scientist prediction is that by 2028, super AI is coming to the industry. Now we come to the AI. In 1988, the first AI PhD thesis has been submitted in Stanford University by the Ted Shortleaf. He's very close friend of mine. He got married an Indian. So always when we meet, I talk, "Aap hamare damat hain." And he loved to wear Indian costume also. And recently he had been to Goa for a marriage. I met him also. He's the first. His thesis is mycin. You can search in the Google mycin. At that time, 1988 in Stanford, it has given a new dimension in the healthcare. Nobody expect that. Means one tools is coming up, it will help the doctor or replace to the doctor. But it has taken 1988 to 2020, the long journey that it has not shape up. Right now it has shape up. Now we come to the AI in healthcare. AI in healthcare, it is a big challenge. It is a different domains. The domain is very complex as compared to any other domains, because the data what we are generating, it is not properly standardized. It is not properly stored. We are getting the data, unfinished data, fragmented data. In the healthcare, we speak always one thing: more data, more healthcare; less data, less healthcare. When we talk to the data, AI models always need a data to train the model. And if you give the clean data, the model will get a perfect model. Otherwise, will not get a perfect model. One example I am giving to you. One person from the MTech thesis from IIT Delhi, he had been to come to AIIMS, do his final semester project work. I have given one model to develop. And he has worked very hard for 6 months, but the model is not performing. And why it is not performing, we are unable to judge it. When he has came to me and cried, "Sir, मुझे पता नहीं है मैं क्या करूं, but मेरा मॉडल काम नहीं कर रहा, मेरा thesis complete नहीं होगा." Then we have seen very rigorously, it has taken 6 days. And we have pointed out that one small mistake. That is that the data has come in 6 hospitals, different sources. In few hospitals, they have taken the patient temperature in Fahrenheit, and some people taken in the centigrade. This is small mistake, whole model has going to be failed. So this is the things what we are supposed to be. But why the AI in healthcare? Right now we are working in the precision healthcare. Precision healthcare means personalized healthcare. And personalized healthcare, the digitization is play a major role, where you can use your genomics data and other information, clinical information, you can integrate it, and you can decide that what personalized care can be done, and it can be predicted through a AI models. Thank you.
Thanks, Dr. Sushil. In fact, more data, more healthcare. Then that brings us to a topic where, if you look at the patient journey, right from prevention to diagnosis to treatment and then post-treatment, there's a lot of data that gets generated, and therefore, how do we utilize some of them? Now, therefore, the question comes also is, in the care continuum, how are we also accounting for the patient behavior? Because we are talking about a very diverse population, people who are aware of technology, people who are not, people coming from different walks of life, and then how are we going to build in, using AI, also taking into consideration the patient behavior in the care pathways? So, Mr. Dwivedi, what in your view, how do you think this also gets addressed? Because ultimately, this industry's emotion and sentiments also play a very important role. You cannot remove the personal touch and replace it with an algorithm, right? So, how do you look at that?
Thank you, Elet eHealth, for inviting me to this forum, and I'm honored to share dais with the esteemed co-panelists. I will come to your question, but first, Dr. Meher has actually expressed and showed the myriad of the experience and the repository of knowledge that he possesses. I will just give some structure to that, and then I'll come to the patient behavior. See, look at every touch point. patient getting in touch with the hospital, either through the app or through website or calling in our call center, then visiting in person, then going and seeing a doctor in the OPD, then coming to give sample for the investigation to the phlebotomist, then going for the radiology examination, then going to pharmacy for taking medicine. If there is a need, going to the admission counter, getting admitted, coming into the ward. Now there is vitals measurement, continuously monitoring of the health parameters, infusion of the medicine, maybe if there is a need, visiting to ICU or operation theater. And there is another route, that is casualty, then being discharged, and then there is a post-discharge engagement. So this covers the entire life cycle of the patient. And every touch point has been affected by these heavy words that are included in today's topic: interoperable, AI-powered, patient-centric systems. Every word is very heavy. And these combined make the, or tend to make the life of the patient easier. So it starts with the monitoring. When you are healthy, apparently there are no problems. So every generation has a different behavior pattern. You know, the Gen Z, boomers, whatever you call the new generation, they are very fan of using the Fitbit or Apple Watch or whatever, and those are pretty much connected to some center, some monitoring center where your health is being monitored. Surprisingly enough, even the oldies are also not far behind, and I can see Apple Watch on every wrist of every generation. So it has really penetrated across the board. Now, how much really actions you are taking upon the alerts that you are receiving is a different story. If you do that, then you move to the healthcare rather than having to go for health repair. That I always say. Now, coming to the touch point, the millennials and young generation who are technology savvy, they'll take on their mobile and look at the appointment slots and everything. The people of prior generation would like to talk to somebody, and whenever they are visiting, they will really look at some person who is assisting. So the assisted service is still, it has not gone, and I don't think it will be gone. But then as technology pervades, probably you will find it more and more easier to deal with technology rather than dealing with humans. So this is a natural progression. Now coming to another behavior, that is your interaction with the patient. I will not take much time, just 1 or 2 more minutes. You are expected to read a lot, either Google or Chat GPT or whatever. It will appear that you know more than doctor. And I was just, reading some joke that a physician has put in. If you have read Google, then your fee is 2,000. And if you are coming without reading, fee is 1,000. So you are coming with a lot of knowledge that doctor has to really undo and dispel a lot of myths that have been created by those YouTubes and all those things. So this is the new phenomena. Then you see doctor also very much assisted by AI, and there is a CDSS, Clinician Decision Support System, which really pops the diagnosis and potential treatment regimen. I can go on and on and on, but every touch point is affected and behavior is also changing gradually. Thank you.
Thanks, Mr. Dwivedi, on that. Maybe Rishabh, your views also on that, because from a technology point of view, in terms of how across the care pathway, some of the use cases and what various technologies are coming and algorithms that you're looking at.
Absolutely. Thank you for the forum, Elets, and thank you, esteemed members, for sharing these thoughts. And what we've realized in the pre-discussion was that a lot of our thoughts actually matched, and there was no real discrimination in terms of whether I'm a next generation person or whether there's a earlier generation person, or maybe I'm the So these are things which resonate across the board. And one thing which resonated was that human beings are not going anywhere, right? And it is the technology which has to assist the doctors. It is the technology which is to assist the care providers, and that is for sure mandatory. And one reason behind it is trust. Today, if somebody is placing their health or their lives in hands of somebody else, they need to be able to trust whoever is providing that, and that trust only can come from somebody who's there, who can give them that comfort. As we said, AI is, let's say, even if it gets to 99% accuracy, right? That 1%, who takes that call on that 1%? Now, this is something which is very human, and this is who we are, right? Tomorrow, maybe we become comfortable with taking a probabilistic approach to our health. Say that, okay, if doctors can get maybe slightly a little more wrong than AI, then we would like to go with AI, right? But yeah, that emotional call, that ability to look at how this is impacting this person, right? That can only come from a human being. So one element here is in terms of behavior. Can the person who's getting treated trust the system? At the same time, the other element of behavior is convenience. Does it provide convenience? Does it provide some additional benefit over and above meeting somebody in person? Let's say you are getting treated at home. Some of the examples I saw today morning, right? Some of the appointment scheduling, the follow-ups, etc., and also some of the care that's happening in government hospitals. All of that is now strengthened by AI. And as you can see, all of these places, it's not the decision making or the core health element. It is a lot of the peripheral, which really a lot of it is effort spent on doing something mundane and repetitive, and doesn't really add to the care of the patient, right? So can we automate some of that material away? Can we strengthen our workflows? Can we improve the patient compliance, the behavior, etc., with some of these systems without really impacting the ability to trust a system, the ability to get proper treatment and have faith on the medical profession? So some of these things would, I would think, at least from our perspective, we've seen that people don't really want to trust pure AI. If there is something, then some human has to look at it. It's called human in the loop. If you don't have a human in the loop, the AI there is very little trust in that human being. And then, of course, one of the discussions that came up in the morning was also around training and education of some of the new people, right? If you give everything to AI, who will train the next generation? Who will take that call on that 1% or 2% risk, right? If you don't train the next generation. So a lot of these points, in fact, I've borrowed from the speakers here, and I hope I've been able to communicate these points accurately. And I think behavior is going to be an important part of any of the AI implementations going forward.
Right. Thanks, Rishabh. That's very key points. One is trust, because whatever we do, any technologies, ultimately the patient should trust the system, should trust the ecosystem. So that's going to be key. That will be the foundation for any, whatever kind of technology we bring it into the system. So therefore, I'm just going to shift gears a little bit, coming into a pure technology aspect. While we spoke about care and things, but today many of us are moving into prevention, right? Should the lot of emphasis on wellness, and therefore any predictive can we move into from towards predictive care or preventive care, right? And then therefore this means again a lot of, if I put in the technology lens, how are we going to look at it? And Mr. Surjeet, with your experience of implementing large HIS, HARs in hospitals, how have you used this data to give proactive alerts to patients, and therefore with more emphasis on predictive and preventive care?
Yeah, thank you. So first of all, thank you eHealth and Elets for this opportunity. I mean, if we look at the healthcare transformation that has happened, and I'm not talking about the digital transformation in healthcare, the way healthcare itself has evolved is, earlier it was episodic care. When we were sick, then we used to go to meet the doctors. And then it changed to preventive healthcare, what you're saying, and though it's still catching up. But now the time, in fact, we're talking about population health. COVID-19 was a classic example of population health. Whether you have COVID-19 or not, you still were given a regime of the vaccination that you need to take into. So, I mean, that is what the entire transformation of healthcare has been. Now, if you look at, I mean, how the preventive alerts and all is actually comes to the same thing. I'll take again the example of COVID-19. The first thing was having the app, which is more data onboarded there. You know how in which diameter how many people are actually are having COVID. Then what is the sort of plan that has to be taken or to mitigate those. So those are being taken. If you put a context to individuals, that is actually what these alerts should do. And I'll give you an example. And this is not on a lighter note. So I'm a member of NASCOM also, where we evaluate where the software companies come seeking for the center of excellence for input and also for investments. So there was a solution which had come similar to Fitbit and Apple Watch, wherein there would be predictive alerts which will come on this in terms of your symptoms and all. And plus it was specific to a patient because there are care plans defined in that. So I can onboard myself into that, saying that I have a chronic disease, for example, diabetes. So based on that parameters, it will prompt me. So they had come and said, we want to, because those alerts are IoT and IoMT devices, automatically alerts are coming. So we want to monetize this model. And when we asked what is the question, we said, we'll throw up alerts. I said, okay, you'll throw up alert that you need to walk 1,000 steps. What happens if I don't do? Their monetization model was they were mixing technology by offering services. They said, we'll have people who will come to your door in the evening, say that you have only taken 6,000 steps. So I will walk with you for 4,000, but you'll have to onboard at a price. So it's not just about alerts, it's how to act on it. So this is just an example. So artificial intelligence data, it's all about tons and tons and tons and tons of data, nothing else. And instead of you whacking your brains, system is throwing up your output. I mean, if you look at all these medical journals, these are very costly. And the reason they're costly is someone sitting somewhere doing the research, concising it, putting it in a document. It's all human, effort intensive. And telling you that now this is also a new case which has come somewhere. So, I mean, doctors go through it, CMEs happen, wherein now going through those documents, you keep abreast of the latest things which are happening. Instead of that, AI is doing that for you by throwing up preventive alerts of saying this is what has happened elsewhere without you even have to think. So, I mean, that is what the future is. I mean, I don't see that you can just discard saying that it's still work in progress. I will not touch. It's absolutely not the case. It is there. And I think it's all about how to act on those alerts which AI is able to give it to you.
Very well said, Mr. Surjeet. You know, in fact, when you spoke about these new models coming up, one of the things that we are seeing is the ways of working is also going to change because of AI. For example, we would have read this in the news as well. There is an insurance company which says, once you buy a policy with me, I will give you a Fitbit and I will monitor your steps. So if you walk, let's say 10,000 steps every day on an average this month, the premium that you pay next month will get reduced. Right? If you don't do that, then the premium increases. So the new ways of working is individuals will start getting incentivized for taking care of their health. So that's new models which are coming. And they're saying even, let's say a pharmacist. A pharmacist may not be a guy just dispensing medicine. He may actually be monitoring your whether you're taking your medication on time, whether your medication it's not been refilled. So he may be actually giving you alerts from that perspective, right? So the role of people gets changed, they get more empowered, and therefore new ways of working will start coming in. And that's where we were discussing before the panel. In the future, will you go to a physician who knows AI or a physician without AI? So which is the one will you choose, right? So that's something which we have to be prepared. And as you mentioned, Mr. Surjeet, this is something we cannot avoid. This is how the world is moving to. So maybe I'll just open up this panel a little more to talk about some use cases that you have done in your respective hospitals. So the audience is also aware of how AI is actually changing some of the work that we do in our day-to-day life. Maybe with you, Dr. Sushil.
Yeah. See, the world is looking towards the 5P. Just we have already 2 points we have spoken on this, preventing and predictive. But another 3P is there: population, another participatory, and participatory and personal. So, okay, this is a 5P. Based on the 5P, because AIIMS is a institute for the national importance in healthcare, teaching and research. So always you work in that mode of working. So these 5P play a major role for us. Now we come to the use cases. Anybody who is reading the newspapers, you must have seen it last 2 weeks back. The news was that 300 crores has been allotted to AIIMS for the developing the different models on AI. And you see, because already the government has given that AIIMS New Delhi is a center for excellency in AI. So this is our responsibility for the society to give a good AI product to the society. They can use it, and this money is not for AIIMS. This money is coming from the public money. So any private or public people, they can use it. One use cases I am talking about, it is very successfully it has done. It is a national project, AIOncology.ai. In 2020, when we have decided that there is a lot of cases is coming up in breast cancer and ovarian cancer, and this is the highest death in the country. So the only one thing is that if you predict that through some models, then more than 80% breast cancer and ovarian cancer can be curable. But majority cases is coming stage 4, so the survival rate is 20%. So this gap, how it can be reduced? Then we have started working on it. We have got the funding for 4.5 crores from the Ministry of IT, and we have started working on it. 30 doctors, they are involved. 10,000 patients data has been cleaned. See, 10,000 patient data, we have cleaned it. It has taken 4 years, and 3 levels of cleaning it has been done. And we have developed that model. There is 7 different mathematical models which is integrated with AIOncology.ai. It is an indigenous model, in-house developed in AIIMS with the help of IIT Delhi, CDAC, AIIMS New Delhi. And right now, the prediction level is 82%. And already 16 hospitals, those who are taking care of the cancer patients, they have started using it. But major challenge is that when we have used the time and efforts to clean the data, that is a major challenge for us. Because if you not clean the data and you put the raw data or unclean data, again my model performance will go down. Try to be more careful on this. When you have got a models, when you are using it, at that time it is performing very well. But you have to see regular basis and audit it whether this model is performing or not. If you will give the junks, then the model definitely go down. So this is one of the things which is supposed to be very careful when you use any models. This model is not permanent, because more data when you give it, the performance will might go up or performance might go down. And that is the major challenge for each organizations, that you have to give continuous monitoring that this model is how it is performing. And that is the challenge for you. Second part is that we have used many places in AI. Already 5 AI models is using it. Early prediction of infection of the newborn disease in the neonatal ward. It is successfully running, and it is a PhD thesis of one of the triple IT in Delhi. Another one is that this is the most successful one, that every year AIIMS New Delhi, 2 or 3 students, they do suicides. We have AI models at the time of admissions. On face recognitions, we can predict that the student is, what is the depression rate. This is one of the successful, and last 5 to 6 years, you may not have any news that any suicide in AIIMS New Delhi. Next one is that we have implemented that smart lab. All the tests, everything is totally a automated system. The robotic hands handling the other samples, the reporting has done AI-based model. So that's why the time has reduced to 80% for us, and we have got more time to use by the doctors for other purpose. Another AI you have done it, patient screening. Patient screening means around 32% of the patients, it is landing to a wrong department. So at the time of appointments, these bots, AI bots, it is screening the patients, and he's directing that this department is supposed to be take the appointments. So this is the things we have achieved in AIIMS. Like a lot of other work is going on simultaneously. Retinotherapy is also, this is also in the final step of this project, which will be implemented, it will come up to you very soon. Lot of things are there. Miscarriage of the means early pregnancy, that is also, it is going on. Already it has been implemented in halfway. That radiology reportings also, each reportings, it was taking around 20 to 25 minutes. Now it is reduced to 10 minutes. These are the things, it is there already in place. But one thing I am talking to you about it, that where to use the AI, where not to use the AI. See, I hope your time.
Yeah.
Okay, thank you. Yeah, let her go.
Maybe 1 or 2 quick use cases, Rishabh, you want to talk about diabetes, and which we were discussing outside, maybe.
Right. So let's say if you're tracking a certain disease, right, and you have to capture all of that data into your system, then one of the implementations that we've done is, for example, extracting the information from your handwritten or printed medical records and then doing a sort of trend tracking. Now, this is something which, let's say, a young person would find it very easy to do, right? And if there is a, let's say, an alert that you should go and see your physician, this is something that they would easily recognize. But let's say a person who's not comfortable with smartphones, who has this big bundle of file with paper records, right? Then for them to get to this information and then for them to actually go out and get some of this will require somebody to assist them or somebody to help them. So what we've tried to do is we've tried to make our systems user friendly, try to make them more technology agnostic. If there is somebody who's not good at doing technology, then somebody else can assist them without really getting into the private details of this person. So some of these things we've also tried to implement, and yeah, this is something which we found as a positive response. So handwritten records to a digitized record is something that we're working on, and that is something which we found a powerful
This
response.
helps a lot in your EMRs, and therefore your quality of data for predictive and preventive.
Absolutely.
Surjeet, you would like to share a few use
Yeah,
cases.
and I'm giving you the use cases which actually is being practiced in a partner hospital of ours, and they have been in operations for the last 10 years now, 10 plus years, and since beginning, it is a paper-light hospital. All the doctors are using it in the system. So I'll give you examples of 4 use cases of AI that we are using in the system. First is for appointment. Because it's largely all appointment patients, and we're few slots for walk-ins, but largely appointment patient. Traditionally, all hospitals will follow the appointment reminders on WhatsApp or on SMS. That is a traditional way. But if you look at that, it is a unidirectional, no intelligence reminder to everyone. What we have done is, based on 12 different parameters, we have used AI to predict whether the patient will come or not. Because we have the entire longitudinal patient EMR, and it is being practiced, so it's not something that I'm making it out. So based on 12 different parameters, in which gender of the patient, gender of the doctor, nationality, religion of the doctor, religion of the patient, the previous history, of course, where does the patient stay? And based on that, we calculate a threshold or the probability. And then there's a cutoff. Higher the probability means the patient is going to come. We don't remind them because they are anyways coming. Where the probability is low, they are being sent multiple reminders just to ensure that they come. With WhatsApp, now we have given them an option, 1 to confirm, 2 to cancel, 3 to reschedule. They can automatically get connected to the call center. That is one use case when the patient is not even there. Then the other thing that we have done, if you look at the discharge summary, traditionally it's a printed discharge summary, templatized, handed over to the patient. Given it to the patient, patient goes away. From a hospital perspective, they are now putting up call centers or putting up marketing people who will go through the entire discharge summary and start calling them. So you are supposed to come for a post-discharge follow-up, or you are supposed to do this investigation, because ultimately the patient is not under your care, but you still want them to come back from a revenue perspective, care perspective and all. Yeah. We have used AI there also, that now system is actually creating a work list for you based on this, that these are the post-discharge investigation, these are post-discharge advice, these are post-discharge consultations and all that. And then that is linked to the CRM, that someone, instead of browsing and reading through the discharge summaries, that system is doing that. During the stay, there are two things that we are doing. Whether we like it or we don't like it, the newer generation doctors are using ChatGPT and HealthGPT. They're putting the content with the individual logins and seeing, and it gives you a beautiful, templatized, bulleted plan of care. We have used absolutely the same thing. So we are using that for the nursing care plan. Okay. Because patient is already there, the diagnosis is there, the previous history is there, the plan of care comes automatically. Of course, it prompts and tells the nursing so that they can edit it as well. The fourth thing that we're using for the doctors is the conversational AI. Conversational AI, again, practiced by the doctors there. It actually filters all the non-medical conversations. It prompts and gives you the allergies, diagnosis, orders and everything. And just with a click of a button, they can of course edit it, but it will automatically go to the EMR. So all of these are happening. And again, I'll say that not all the doctors are using the conversational AI. Many are comfortable putting it in the system itself. But there are many who are actually doing this doing the NLP, primarily the natural language processing, using the AI to do all this. So these are the few things that we are actually doing it in our hospital.
Very, very, very interesting and well put, Mr. Surjeet. I think one of the things that we should be also cognizant is, while this technologies are there, it is only to help reduce the diagnosis cycle, put the patient into a treatment cycle much faster so that he's in a treatment much earlier. So that's how we should look at it. I know we are short of time, and it's an excellent panel here. A lot of, I think this panel can go on and we can keep talking about multiple use cases. Thank you so much. Yeah, Doctor.
Yeah. I have gone through there's 5 countries already, they have regulated the AI. Okay. And one of the best document, it is European Union AI regulatory, which is supposed to be implemented in February or March. They have already defined that where to use AI, where to not to use AI. But they are very concerned about one word you can search in the Google, subliminal. Subliminals is one word which is influence your model, how it will influence the model. That is, you should go through it, then you will know that how unknowingly you are influenced and data has been changed. It is the meaning, subliminal. Thank you.
Thank you, Dr. Sushil, and thank you, panelists. Thank you so much. I think some of the keywords that I also learned today, healthcare versus health repair. And if there is more data, there is more healthcare. We spoke about trust and how the trust should be looked at. A lot of interesting use cases which we are already implementing, and I have the opportunity to look at what's happening around the globe, because I sit on some of the global life sciences leadership and healthcare leadership team for Deloitte. So I also know what's happening across across the other countries. And I will tell you, India is much ahead in adoption of these technologies because we have the ability to skip a generation. We can do 2G, quickly move to 4G and 5G. Look at DigiYatra for us. We started with the passbook-like ticket entering into the airport. Today, we don't carry anything. It just recognizes your face, you enter the airport. And this is something which the global airports also don't have, right? And they are trying to replicate from India. I think as a country, we have the ability to quickly adopt new technologies and create a lot of disruption. And we are seeing that happening today. Thank you very much.